research professor now in the Department of Pharmacology and an emeritus professor from, again, the University of Illinois, Chicago. This morning, she's going to talk to us about improving our patient success rates using the powerful genetic testing available to us today. Welcome, Dr. Liebman. The floor is yours.
Thank you so much. So I want to begin by telling you how I came to be here. How does a research geneticist who is working on model organisms and studying protein misfolding diseases come to give a talk on clinical genetics? And the answer is that my family history of genetic disease has made me an advocate for genetic testing, and my background in genetics fed into that a bit. So what I want to hope to convince you is that genetic testing is emerging as an essential medical tool, and that it may end up having as much influence in changing medicine as did the use of antibiotics. You're all aware of the importance of studying carrier mutations in reproductive health. That's not what we're going to be talking about today, although it's obviously a very important topic. What I do want to impart to you is how you can order a genetic test, and I want you to understand that although when genetic testing was born, it was very expensive, it's not very expensive anymore. The average cost of a genetic test now panel is $250. I also want to encourage you and counsel you that you do not need to be a geneticist to order and do a good job with genetic testing. There are genetic counselors available from all of these genetic testing companies that will help you along the way, every step along the way. So genetic disease, we all know that you get one copy of your genes from your father and one from your mother, and the DNA that's important for genetic disease is by and large all coding for protein. So it's going from, and the protein is the workhorse in the cell. Having the appropriate protein is what's important and keeps us healthy. Usually we have two versions of slightly different versions of the protein, one from our father, one from our mother. The differences may be almost no difference. They may be very slight differences due to unimportant changes in the genes. But genetic disease occurs, and I'm going to be talking today about dominant genetic disease, when there's a mistake in the DNA, and that mistake results in an altered protein. Often it results in loss of function. The protein doesn't work at all. Now, if we're talking about a dominant mutation, loss of half of the protein is sufficient to cause disease. In a recessive mutation, then half the protein would be okay. But another way you can have a dominant disease is not just that you've lost half the protein, but the protein is bad and it interferes with the activity of the good protein. So how can genetic testing help your patients? The first thing is it can detect disease early. By screening, you can find mutations that can cause breast cancer and death, or hidden heart disease mutations that can cause, for example, sudden death. There's other things diseases that can also be detected early that can be of great help. I will present one case history about a family with sudden death, and you will see how screening could have saved the life of a 36-year-old woman. But there's no point in doing screening if we don't have you guys out there following up. You have to follow up in the clinic is essential to make the screening valuable. Another reason that genetic testing is very useful is it can help you get a diagnosis. Often you have patients with symptoms, but it still doesn't lead to a diagnosis. And sometimes there's years of delay in getting a diagnosis. And I'll describe two case histories involving hereditary spherocytosis and hereditary spastic paraplegia that enabled a diagnosis. And finally, not only can you protect your patient, but by finding disease-causing mutation in your patient, you can help that patient help their families. And often the family already knows there's a big problem, they just don't know what the mutation is. And you can also reassure members of the family that don't have the mutation that they don't have to worry about that problem anymore. Currently, the American College of Medical Genetics and Genomics have listed 73 actionable genes. And just last month, they came out with this panel. Every year now, they will be upgrading this list. This is version 3 of their list. And actionable means that you can intervene to make a difference in the prognosis, life expectancy, and quality of life of the patient. 1 in 50 adults that is tested for these 73 genes will have a mutation in one of the genes. And so it is recommended currently that likely pathogenic variants in these genes be reported to patients even when they are detected in a screen that is unrelated to the primary medical reason for testing. So if you're testing for something else and you come across one of these 73 genes, they're asking you to report it to the patient. And I'd like to tell you that the American College of Medical Genetics is currently accepting nominations from people like you for other genes that should be added to their list. And I hope you'll consider letting them know about genes of interest to you that you think could help your patients if they were added to the list. Okay. Don't want to get so the reason that they make sure to only list actionable genes on their list is they want to avoid having you guys end up with conversations like this with your patients. Gee, I think you should have chosen parents with better genes. They want you to be able to say something better than that. Okay, so among the list of actionable genes, there's 28 that affect hereditary cancer. There are 33 that are involved in cardiovascular diseases and 12 that cause other miscellaneous diseases. So here's an example of some cancer genes and the effect of having such mutations. So let's look here at BRCA1. In gold is the average risk that can be expected of getting the disease on the left. So the average risk of breast cancer for a woman in the United States who does not have BRCA1 is indicated here, and the increased chance to 81% is due to the BRCA mutation. Notice that this is not 100%. We don't know for sure that somebody is going to get breast cancer because they have the BRCA mutation. Other mutations and other diseases, the penetrance or the chance that the person will actually get the disease if they have the mutation is even less. But the chance, because they have the mutation relative to not having the mutation, is tremendous. And if the warning that they may get the disease encourages us to catch the disease early, then there's a 98% chance when breast cancer is caught early of a 5-year survival versus a 25% chance of a 5-year survival when it's caught at a late stage, and the same kind of thing for the other diseases. So I am proud to say that Nevada is the first state in the nation to put out a bill implementing the U.S. Preventive Service Task Force's recommendation. And what the bill tells is that primary care providers must try to determine a patient's personal or family history of breast, ovarian, tubal, or peritoneal cancer, or the family connection with a harmful BRCA gene mutation. And if a family risk assessment tool indicates the likelihood of harmful BRCA, the primary care provider must counsel the patient on risk and suggest genetic testing. And then the health insurance in Nevada must cover this testing that meets the above criteria. So you can see that there is, first of all, let me say that right now in the United States, there's very little genetic testing. With laws like the one that we have in Nevada, there's a push to start to get genetic testing in response to family history, to use family history for genetic testing. However, in reality, there's a need for genetic testing for universal screening for everybody. And here's the reasons why. 1 in 2 people with BRCA have no family history with BRCA mutations. 1 in 5 people with no family history still have a genetic disease. 1 in 6 people that you get tested for genetic disease will have actionable change in care. There are over 50 known hereditary cancer syndromes, and 1 in 250 people have a hereditary heart disease problem. These problems and other genetic diseases are not rare. We used to say that genetic disease was rare. That was because we just didn't know about all the genetic disease that there is. So compare these numbers with numbers of diseases you're familiar with. In the United States, 1 in 300 people have HIV. 1 in 500 people have Crohn's disease. 1 in 500 people have ulcerative colitis. So where could you send your patients for genetic screening? Again, we're very blessed in Nevada to have this wonderful Healthy Nevada project in collaboration and help being supported by Renown. And it provides free sequencing for anybody in Nevada who registers for this test. You give them your saliva and they will sequence all of your protein coding genes, all 23,500 of them. And they will, you sign off that you allow them to use the data without your name associated in research. The immediate value, besides helping research and helping us all learn about genetic disease, is that they currently will report to everybody the results of 11 CDC1 tier 1 genes. So it's not all 73, but it's the most important that they've chosen of those 73, 11 of them that cause familial hypercholesterolemia, breast, ovarian cancer, and Lynch syndrome. They have left open the possibility, since they have all of the sequences of everybody, to report on other genes in the future. And I, for one, am hopeful that they will find the funds and ability and interest in reporting on all 73 genes. I know they don't have the money now to provide the appropriate follow-up to do that. And perhaps some of you in Renown can help make that happen if I convince you of this importance. By the way, I have no connection with the Healthy Nevada Project. Currently, if you're interested in all 73 genes being screened, there are many commercial laboratories and other nonprofit sequencing labs that will, for $250 to $350, sequence many of the actionable genes. I haven't found one that for a reasonable price will do all 73. The ones that do all of them do many more and cost more, but 67 out of 73 plus 80 others, and many of the appropriate cancer genes and cardio screen genes and pharmacogenetics. Let me mention that the 73 genes is a bare minimum. They have excluded many other genes that could be on that list, and that's why they are open to nominations and will be expanding the list year by year as we learn more and as they get more information. So I'm going to skip this slide and we can come back to it later if you're interested, that describes other companies where you can get screening done. So what kinds of results can you expect to get if you do this screening? For example, Healthy Nevada will tell you if any of the 11 genes that they screen are have mutations that make them pathogenic or likely pathogenic. The other screening companies will likewise only report pathogenic or likely pathogenic changes in healthy adult screens. I can't stress enough that different companies will score these differently. In some cases, they'll decide it's not likely pathogenic. The answer that you get is a snapshot in time for whatever software the company or the organization is using to decide on pathogenicity or not. So that repeated testing is helpful because this determination will change in time. And the other very important thing is that just because your patient has a pathogenic mutation, they may never get disease, as we saw in that list with the cancer genes. What's essential is that there be follow-up and clinical care. And there are some genetic mutations that they have a much lower chance of causing disease than the ones we saw with the cancer. They may, give you a 25% chance of getting disease. It's still very important to know. It's still something to take into account, but it's not something that your patient needs to be terrified about. It's just information that should be added and considered in their medical history. Okay. So how would you establish a genetic testing order? Two ways. The first is to get help, full service help. There is a connection between Renown and a company called Genome Medical, and you can simply refer your patient to Genome Medical through Renown. If you do it through Renown, there's a break in price for many of your patients. And they have genetic test counselors who will find the appropriate test, find the appropriate company to order the test, depending upon what you told them about what you want for your patient. They will place the order. They will speak to the patient ahead of time to decide on all of these things. And this costs, which may be covered by some insurance, $179. Plus, they will charge them whatever the company costs, but they make sure it's not going to be more than $250 for the company cost. And then they will speak to the patient at the end also for a fee if necessary. The other thing you can do is order the test yourself. But when I say yourself, you're not really by yourself because the companies all provide genetic counselors and doctors, geneticists, who will help you choose the correct panel for your patient. So if you call them up and ask for advice, they're happy to discuss this with you. And then when you get the results of the tests, and the results are very detailed, they will discuss the report with you at no cost. And some companies will even have genetic counselors that will speak directly to your patients at no cost. So you have those various choices. What kinds of orders might you look for? If your patient comes in and says, well, my sister's been found to have BRCA, now I need to be tested. So you, if it's appropriate, you would just test this patient for a single gene, and that generally costs about $250. I'm saying here self-pay, just a little. Some companies have a self-pay and an insurance pay price. The self-pay price is much, much lower than the insurance pay price. If you know for sure the insurance is going to cover everything, that's great. But if the insurance then denies coverage, the patient becomes responsible for the higher insurance billed amount. And they are not allowed, once the results are obtained, before the results, they can still switch. But once the results are obtained, they cannot switch to the self-pay price. Okay. If there is a disease in the family or just in your patient that you are concerned about and you want to investigate whether it's due to a mutation in the gene, you can choose a panel appropriate for that disease from the website. You can, again, talk with the genetic counselors and physicians at the company to help you. And also be aware that there is a lot of sponsored free testing. In particular, I know of cardiomyopathy and arrhythmia and ALS. Again, the patient must agree to allow their data de-identified to be used in research, and then they will provide free testing for the patient and their families. So how might you find a disease panel if you're doing this yourself? So this is an example from one genetic company. They list all of the diseases that they have panels related to. And if you're interested in cardiology, you would give a click here on cardiology. Then up would come the list of all the heart disease genes that they have genetic panels related to. Let's say you're interested in cardiomyopathies, you click that, and up come all the panels that they offer for genetic testing for. And if you click on them, they'll tell you the genes in their panel. I would recommend, I always look for the combined panels. So this panel includes everything. So they all cost $250. You just have to sort out what your results are, but this way you don't have to come back and do it again. You've got everything done at once. Okay. So while I'm on panels, let me talk about the advantage and disadvantage. The advantage of doing a panel is you've got the list of genes, you know exactly what they tested, you know the result of what your patient had for all of those genes, and if necessary, in future, you can do it again and know there are new genes there. The disadvantage is when they set up these panels, it's fairly expensive for them to make the panel, and they don't make new ones very fast. So even though they know there's new genes that should be added to the cardiac panel, they haven't quite gotten around to adding them yet. So it's not as fast as I would like to see it. And again, retesting in a few years can solve that problem. Okay, so when I described genetic disease before, it was a little bit simplified. This is really not at all complicated, but what I want to show you is that the DNA contains regions that we call exons that are the part of the DNA that actually codes for the protein. The introns are stuff stuck in that doesn't code for the protein, and that stuff, the introns, are spliced out. And so the message that is actually used in translating the code into protein doesn't contain the intron DNA after it's mature. The intron's been spliced away. So when we work with panels, they are only sequencing the exon sequence of the DNA. There's a lot of intronic sequence, and they're leaving that out. They'll sequence the exon sequence and then just the borders to make sure that the splicing is happening properly. Okay. So what's another kind of, besides a disease panel that you can order? Sometimes people get tired. They've ordered one panel, then another panel, then another panel. They still haven't found their disease, their smoking gun for the disease. And so nowadays it's become quite cheap to just do the whole exome all at once, sequence all 23,500 genes, which include 60 to 85% of all known disease mutations. And this is just a small portion of the whole genome, because the rest is in DNA in between genes or in introns. But it gets you all of the protein coding sequences. And the cost here, I can't see it. Okay, the cost here is on the order of $2,000. Even so, you have a great deal of information from 25,000 genes, the genetics company. And in order to come out, and each of us have many mutations that are harmless, mostly harmless in our DNA, or totally unrelated to the disease you're interested in. To find out and pinpoint which of these changes is likely to be causing the disease you're interested in, a technique called trio analysis has been used. And this just means getting the DNA from two relatives in addition to the proband. one who has the disease or symptoms, and one who does not. And then any mutation you find that's also found in the person, the relative who does not have the disease, is eliminated. And any mutation that is found that does not occur in the relative who has the disease is eliminated. And this eliminates large numbers of the wrong mutations and helps the analysis tremendously. But sometimes, even with whole exome sequencing, the mutation is not found. And sometimes people, for certain kinds of diseases, prefer to go nowadays into sequencing the whole thing, whole genomic sequencing. This is sequencing 100 times more DNA than the exon sequencing, but it doesn't cost all that much more. It's a little more than $2,000 for Trio, it's $5,000. By the way, the Trio, they don't sequence the entire genome of the other two relatives. They only look at those genes that they're concerned about from the sequence of the proband. And the last kind of DNA sequencing, oops. Where is that going? Okay. Well, we've skipped, oh no, that's my mistake. Okay. So the problem with whole genomic and whole exomic sequencing, just like I told you there was a problem with the panel sequencing, you didn't have enough genes. Here you have plenty of genes, they've got all the genes, but what are they going to tell you about? So each company has its proprietary software program, and they enter what you've told them about the patient's symptoms, the patient's family history, and they also enter the entire exome or genome DNA sequence to the computer program. And then you sit at the edge of your seat waiting for the answer, and this program, this computer, HAL here, gives you the answer, and very often the answer that you get is this. And it can be very discouraging. If you go back and say, well, which genes did you look at from which panels have been covered? The answer is, we don't know. HAL did it, and we don't know what HAL used. So you don't have any genes you can cross off. I hope that this will be changed soon, and I think it will. But for the moment, that's something to ask about if you're going to go for whole exomic or whole genomic, because you may not know what you get. They will reanalyze in a few years and see if HAL has new answers. So here's the last kind of sequencing that I won't talk about unless people ask questions about. There are some genes that are very difficult to sequence, and a different sequencing approach has to be used. And these are mutations that involve a repeat, continuous repeat of sequences. And they're often found in diseases like Huntington's, ALS, and colon cancer. So what kinds of findings will you get? What will they tell you about genes if you're sequencing patients for disease, not general screening, but for disease? There's a 5-point scale. They'll tell you, no problem, the change is benign. No problem, the change is very likely benign. Then we've got this, we don't know what this change is. Likely pathogenic and pathogenic. Again, as before, different companies may score genes differently. The answer is a snapshot in time, and repeated testing is helpful. Also, as before, just because it is pathogenic and can cause disease in some people, it may never cause disease in your patient. Follow-up clinical care, however, is essential. You can't forget about it. You've got to keep checking on the patient. So what do we do with this in the middle? They call them variants of unknown significance, VUS. And there's a lot of controversy in the field as to what to do with those results, and different physicians approach it differently. Here are some suggestions. Some people will ignore these, forget about them, especially if there are other pathogenic or likely pathogenic causes of the disease. If you've got a better candidate, you can forget those. Others will keep it in mind, or if you don't have a better candidate, and re-examine these possibilities in a few years. And the other possibility is to take things into your own hands and to look up on the ClinVar genetic site everything you can about the variant. So on this ClinVar site, they list every known variant. You can find out if this variant's ever been found before, what other variants in that gene have been found, and which ones cause disease. So the kinds of mutations that very quickly review that can be found are missense mutations, where there's just a single base pair change, which will change one amino acid in the sequence of your protein. And that may or may not cause a problem. It's very possible that a change like that will make no difference, but if it's in an important place, it might. Then there are single base pair changes that cause the protein to no longer insert an amino acid, but to stop. That's going to be a truncation. That's likely to be a big problem for your protein, and it's likely to cause loss of function. And then there are frameshift mutations where an insertion or deletion of a base pair will throw the whole reading frame out of focus, and so the rest of the protein's all junk. That's also likely to be loss of function. And then the other very frequent kind of mutation is a splicing mutation, where the exons are not spliced together. The introns are not spliced out properly. And those, again, are big problems and are likely to be loss of function. Okay. So now let's get to the case studies. In this first case, the proband was a 56-year-old woman diagnosed with dilated cardiomyopathy. The father died of a heart attack at age 66, the grandmother in her sleep at age 60, but no cases of dilated cardiomyopathy. And the patient had no risk factors for dilated cardiomyopathy. And so it was stated that she likely got this disease as a result of a virus, as a complication from a virus. But a few years later, her daughter, at age of 36, suddenly died. And then the autopsy showed that the daughter had dilated cardiomyopathy as well. And then it was assumed that, oh, this is probably genetic after all. And at the time, there were about 10 genes known to cause dilated cardiomyopathy and sudden death associated. And all of those were dominant mutations. And so the proband was tested for those 10 mutations, but she did not have a mutation in any of those genes. But it was assumed that she probably had another mutation in a dominant gene, and that she gave the bad gene to the daughter, and the father gave a good gene, but one copy of the bad gene was sufficient, and so the daughter got disease. And it's unknown which of the parents, one can hypothesize, but it's unknown which of the parents gave this daughter the bad gene, but we're hypothesizing here that it was the father. Then there would be a 50% chance that the other sibling would also inherit the bad gene from the father. And there's a 50% chance that the brother of the daughter who died would also have inherited the bad gene. And so the cardiologist recommended that all first and second degree relatives, all of these four, undergo yearly echocardiograms. And this patient went to his doctor and related that information, and the doctor said to him, is your mother sick? Does your mother have dilated cardiomyopathy? And he said, no, my mother's perfectly well. And so he was advised by his physician that you don't need genetic testing because your mom is perfectly healthy. And so I want to ask you guys if you can answer in chat, or maybe raise your hand. I don't know if I can see very many of you. Was this physician correct? Is this true that the genetic testing was unnecessary because the mother did not have dilated cardiomyopathy? I'm going to wait. Can I see something in chat? Or somebody unsilence and answer, please.
Hi, this is Mordechai. I think it just depends on what your kind of sensitivity threshold is to find disease. You know, some things we do only have 25% efficacy to, which you could argue maybe this has too. So I think it just depends on if you think 25% is relevant. But I don't know if it's right or wrong.
Thank you. It is correct that we do not know, just because the mother does not have dilated cardiomyopathy, we don't know that she doesn't have the mutation that causes dilated cardiomyopathy because of penetrance and because it may not have, the disease may not have appeared yet, but she could still has a 50% chance of giving that mutation to the son. So thank you. So what I want to stress in this talk is that family history can be tricky, that even if someone has the disease-causing mutation, they may not show the disease now, or they may never show the disease. And even if they, and the penetrance is a term I'd like you to walk away with, tells you the chance that someone who has the mutation will actually get sick. And in the 73 genes that they've chosen for genetic testing, they try to choose mutations that have high penetrance. Eventually, in this family, the cause of the mutation was found. It was in the FLIN-C, and I just wanted to show you, so you can see the kind of thing that you will see in a genetic report from one of the genetic companies. They'll tell you it's heterozygous, it's pathogenic. And then in the genetic counseling report, they give you a tremendous amount of information. Left dominant arrhythmogenic cardiomyopathy causes sudden cardiac arrest in carriers, in truncating or loss of function mutations. Screening should include structural and functional evaluations. Treatment options for cardiomyopathy could include beta blockers, calcium channel blockers, implantable cardiac defibrillators, or transplantation with advanced disease. So there's a tremendous amount of information. So now that this family had the knowledge of the mutation, it was time to let the larger family know that they might want to get checked to see if they have this mutation. But who to tell? The people on the father's side or the people on the mother's side? Well, we really don't know who had the mutation here, and they're all dead. So we can't get their DNA. And that's where DNA banking comes into play. It is now very easy to spit in a tube and have you or your patient's DNA saved for future generations. And in one procedure, it costs less than $400, and they'll give you a tube with your DNA that's stable at room temperature. You can save it forever and use it 3 generations later when they need it. Another company offers for less money to put your DNA in several of their freezers, all in different cities, and make it available to future generations. Okay, the second case study was a young woman who had recurrent infections, frequent gastric distress, upper endoscopy was negative. At age 20, she had acute pain that resulted in the discovery that her gallbladder was destroyed and the gallbladder was removed. And at age 30, she had pancreatitis. And while in the hospital with pancreatitis, one of the interns actually, instead of sending her blood to be counted by machine, looked at it under the microscope and noticed that there were round blood cells, 2 round, and gave him the idea that she had hereditary spherocytosis, and further blood tests confirmed that. And finally, she had appropriate treatment for hereditary spherocytosis. Here, years later, genetic testing showed that she had a mutation in this SLC4A1 gene. And looking at this genetic report, I've done that yellow highlighting. They're telling you that this mutation is likely the cause of the related blood cell disorder. It has a mutation in exon 17, the 17th protein coding region in the gene, caused by a deletion of a nucleotide. And see the note. In the note, they tell you this is a frameshift mutation involving this gene. All this other stuff in white, they're telling you nothing was identified in these genes. All of this stuff was identified, but it's unlikely to be important. They change this amino acid to this amino acid. Nothing important here. And even in the gene of interest, they change this amino acid to that. What they care about is the frameshift mutation. Okay. The family history here is that the proband had the disease and had the mutation. Neither parent had either the disease or the mutation. This was a new mutation in this patient. Each of us get about 70 new genetic mutations when we're born. Most of the time, these don't cause disease. Some of the time they do. In this case, it did. This gene is currently not on the list of actionable genes, of the 73 actionable genes. And the last case is a proband at the age of 50 that had onset of muscle wasting, and he had a family history of ALS. His mother died of ALS at the age of 70, and uncle also died of ALS in his 70s. However, the physicians were quite convinced that this was not ALS, and they had no diagnosis for this patient. Whole genomic sequencing revealed a loss of function mutation in the ALDH18A1 mutation, and other loss of function mutations in that gene in other patients had caused hereditary spastic paraplegia. So it appears that, trio analysis was done for this patient. Even though his mother was deceased, her DNA was banked, and they were able to find that the father, who did not have disease, did not have this mutation, the mother did carry the mutation. And so it appears, and she had no other mutations that are known to cause ALS, likely a misdiagnosis of ALS that should have been hereditary spastic paraplegia. So there's only a few genes that we talked about now that really, not few, but there are not a large number of genes that you have great cures for, genetic cures. You certainly can intervene, and it's very valuable. But in the future, every genetic mutation may be able to be cured because there may be genetic engineering available and something to keep abreast of. The first cure is for spinal muscular atrophy. The mutant gene in SMN1 can be replaced with a working copy of a SMN1 gene using a virus to infect the cells with the new gene that contains the good DNA. And so I want to leave you with the take-home message is that genetic screening can lead to early treatment and protection for your patient and for their families. It can protect against such things as sudden death or late-stage cancer. You can intervene by knowing the mutation is there. Certainly, targeted testing is essential if there's a family history of disease. But the family history is often not obvious because of penetrance and misdiagnosis. Therefore, the genetic community is beginning to consider screening for all patients. And I was talking yesterday with someone who's on the American College for American College of Medical Genomics, and they are getting ready to put out a recommendation for screening using tiers of genes that should be screened among the 73. But genetic screening and learning that a patient, that you have a likely pathogenic mutation is only useful if there's clinical care and clinical follow-up to intervene. Also, genetic testing can aid in diagnosis. There's rapid progress going on in this field. It's important to keep abreast of the changes and to know that the prices, even the prices that I've described, are going to be dropping and dropping. We talked about the advantages and disadvantages of disease panels versus whole exomic and genomic sequencing, the value of DNA banking so that the trio analysis can be completed. And so I wanted to, and I did put in the chat two links, and Corinna is also going to post those for you. I've learned that the Jackson Lab has a whole series of continuing medical education courses from which you can get credit on medical genetics. And I looked at some of these courses, they're great. So I definitely hope that I've inspired you to be interested enough to look these up and to take some of those courses. And there's also a short pamphlet that I came across that is a guide for interpreting genetic results for non-genetic providers that you may find useful. I'm happy to answer questions now. I'm also happy to have you write to me and contact me in the future anytime. I'd love to meet you and to answer your questions. So we can, Corinna, open up to questions.
Yeah, if anyone wants to unmute themselves to ask questions, that's fine. And then we had someone say if you can put up the slide with the companies that you recommend again.
Okay, so the one here, let's get testing on mom. Well, they couldn't because they didn't know the mutation then. Later, they did get testing on mom, and mom did not have it, and then the kids didn't need it at all, didn't need to be tested. Okay, you wanted to see the, let's see. Oh, I think, yeah, here's the other genetic screening options. J-Screen is a nonprofit, and they do the cancer screening for more than 60 genes. They're looking into doing the 73. They're in talks with Myriad, and they have a self-pay of $300, and they'll still charge you $149 if insurance pays. GeneDx has a combined cardiac panel for $250, comprehensive cancer panel. Again, this is self-pay. Invitae has what they call the genetic healthy screen. They have 147 genes in that. It's almost all of the 73. They're lacking 6 of them. You see, these panels are not easy for them to fix, to change. They have cancer screen that the same 60 genes, because Emory works with Invitae, cardio screen for 75, and pharmacogenetic screen. Each of these costs at $250. And then there's the more extensive screens. Prevention Genetics will screen, has chosen 4,800 clinically relevant genes that they will look at for almost $1,500. This includes all 73 genes. And Ambry Genetics, likewise, has a self-pay price of $1,400. They have 500 clinically relevant genes, which include all 73. So that's my slide on private genetic screening and what I've learned.
Can I ask a question? Is there any data that shows for the patients who we recommend lifestyle changes, healthy eating, decrease your cholesterol, get more exercise because you're at increased risk of cardiovascular disease? Does this information help people change behavior? Is there any data to show that?
I don't know of any data, I'm sorry.
Or compliance with screening. You know, we already have a compliance issue with screening for colon cancer and breast cancer. So I'm wondering if it increases their desire to. to get those screens?
I would hope that it certainly would for me. I guess it very much depends upon the patient. It also, I think, will increase the vigilance of the physician to keep reminding the patient and to encourage other testing in the patient. As far as lifestyle changes, one of the criteria in the 73 genes is that the intervention has to be more than lifestyle changes. So they're either drugs or surgery or some other kind of intervention. But I do think finding that you have, it should aid compliance, especially if people start seeing, in their family that people have died and that they have the gene and other people don't. It should give them more, but I don't know of any data. Other questions? So Mordecai, did you think that 25% chance is not sufficient to do medical screening or to do genetic screening?
Oh no, I think that's about as good as our mammograms, if
Yeah.
as far as making a difference. So no, not trying to imply that, just trying to
good.
point that out, as
Yeah.
that would be my main decision point. Yeah.
So one of the main points that I wanted to stress is that genetic disease is not rare. It can be intervened. It can help with, although there's no data, with compliance, and it's not expensive to have your patient get tested, and therefore you or specialists or their next doctor will be more encouraged to intervene and help prevent disease. It also can be very reassuring to family members who there's sudden death in the family and they don't know if they're next. If they now know they don't have the mutation, their lives can be totally changed.
Dr. Bronander would like to know, what is the turnaround time on these panels?
It can be as short as a couple of weeks. And some of them you pay extra and you can get it very soon. The genomic sequencing very much depends. A company that I didn't talk about, Variontech, who specializes in these repeat sequences, they have a 10-week turnaround for their genomic sequencing, whereas Prevention Genetics has a very short turnaround in there. They can do it in 3 weeks, the genomic sequencing. I think some of these companies, the turnaround time is getting a little slower. They're getting overwhelmed because people are quitting, as they are in every field, and more people are getting involved in genetic testing. But it doesn't take as long as it used to take by any means.
Okay, does anybody else have any other questions? You can type it in the chat or unmute yourself. Someone said, wondering if these tests can be performed in utero.
You can get a genetic test. That's not something I know about, but I wouldn't say these tests. There are different tests that they do in utero. Well, you could test for, yes, you could certainly test for a specific gene. So if somebody wanted to avoid a bad mutation, they could do that. But the goal is to do it before the child is born in the parents. Generally, the carrier mutation screens are done in the parents.
Okay, any other questions? Okay, thank you so much. I put on the chat, if you guys want to claim CME, you guys can go ahead and click that link and then.
So I
we
see
will-
9 things here. Okay, I guess we've answered all of these. Okay.
Yes.
Oh, just comments. Okay, thank you. Okay, well, thank you very much for the opportunity, Corinna, to follow my passion and get to advocate for genetic testing. And I hope I've encouraged some of you to look into these Jackson Lab courses and to incorporate genetic testing in your practice.
Yes, thank you. We appreciate your talk. Thank you, everybody.